My name is Galavo Neto, and it's a pleasure to be among you today. And I wanted to thank you very much the invitation of my dear friend Shashank Shah to speak about it. And the topic of my presentation will be the differences between the lab gastric glycation and the endoscopic glycation of the stomach. So, as you can see on the screen, the laparoscopic glycation starts by taking down the vessels of the greater curvature and invaginating the gastric curvature with sutures that can be interrupted, continuous, observable, non-observable, one layer and even two layers. So you can see also the sagittal cut on that, how it's effectively invaginating to that. So what is the laparoscopic greater curvature application? It is a bariatric surgery designed for morbid obese subjects and has mixed results in literature. The long-term durability have been assessed but questioned, and is the least performed bariatric procedure worldwide nowadays. Also, it is a gastroplasty, and as I told you, not a single part of the stomach is removed besides the vessels and nerves of the greater curvature, and this invagination is very effective on that. Effective at the point that the intraluminal pressure environment of the stomach, that is a low pressure, high compliance system, goes to a high pressure, low compliance system, one similar to what happens in the sleeve gastrectomy. So it works by restriction, by increasing the gastric emptying, and also it can cause minor change in GI hormones that for the paper studies up to now. And in terms of complications, have low rates, and despite the low rates, it had created kind of new ones like the leaks, and the leaks are ischemic, and for the increase of pressure and taking down the vessels causes ulcers and ischemia, and this pressure can leads to leaks. They have mucosal hernias in between the sutures that was described, and it looks like a diverticulum. And the initial days are really challenged, like intragastric balloons, due to nausea and vomiting, and prevents an early discharge that can have some of advantage of these procedures, that is the low cost. So among quite some papers in the literature, so we revised around 30 papers of laparoscopic greater curvature application. We had published, group had published a systematic review and meta-analysis with short and mid-term results. And as you can see here, the structure of a meta-analysis ends up in 8 papers that could be evaluated for that. And this is this graph that can show you exactly what we found in this paper. So the weight loss is significant with the RGCP, but not as the same of sleeve gastrectomy, that significantly have better results in terms of weight loss and durability, and has more identified advantage when compared that. And the gastric application, the lap gastric application, has the advantage of being a technique that you don't excise part of the stomach, and also for the price on that. And you can see here that all the results of this meta-analysis points to advantage of sleeve gastrectomy on that. And nowadays, with cheaper staples, the initial advantage of the lap application that only being using suture and energy source, they are like low when compared in that position. And how about the sleeve gastroplasty done by endoscopy? So as you can see here, we use very specific device, a double channel scope with device attached on the handle on the tip. It emulates like a needle holder, where we have our grasper in the form of corkscrew-like that we dig into the mucosa up to the deep muscular layer, and we put it inside the two jaws that you can see outside. We have a surgical grade needle with proline 2O. Then we close, we exchange the needle, and we pass the needle one side to the other, as you can see globally on that. But we can show you better on this animation that we go to the stomach. Our aim is to work on the greater curvature as the laparoscopic application. So we, as the laparoscopic application, start on the incisura, and eventually you can mark the anterior wall and the posterior wall. It was the very beginning, so very few groups are still doing that. And with this suture machine, we go to the anterior wall, weighted curvature, posterior wall, and there's a different standards of suture. This was the initial one. Again, anterior wall, weighted curvature, posterior wall. Then we drop the needle, it acts like an anchor, and then we have a cinch device that looks like not pusher, and we fire another clip. So with that, we can modify the anatomy of the stomach. The intention here is just to work on the greater curvature and on the proximal part of the fundus. So what it is a bariatric endoscopy procedure designed for non-morbid obese patients. So the target population 30 to 40, better results 30 to 35, very promising initial results, and so good that it's enough to start the clinical practice. We have mid-term durability studies, and it has started to be done worldwide, becoming popular nowadays. So what you have on your screen right now, it is like a timeline. So we start in 2012, the initial series, adapting the technique. Then 2013, 14, first larger series, 15, 16 international combined series, and you see that in 2017 you have the first big series coming from Saudi Arabia with 1,000 cases, and as we speak, 19 and 20, level 1 data is being provided by means of what we call the merit trial, prospective randomized controlled trial done in US, a big one, and also our team in 2020 published the Brazilian consensus with a large number of patients, 1,828 patients that we will be evaluating right now. So more than 80 papers published right now, and you can see that even a single paper coming from Cornell with 5 years results that points to initial 203 patients, study up to 5 years with 89% follow-up. That's a very good rate. And the weight loss was around 18.7 kgs, and percent of total body weight loss 14.5%. And the percentage of patients that achieve more than 10% of total body weight loss is 70% at the end of 5 years. During this whole time, 2 upper GI bleedings, 1 perigastric collection that were treated conservatively. Just to know that around 30 to 40 patients get up to the 5 years, but it is there. So you can see the graph of weight loss up to 60 weeks, and you can see here that the drop was very consistent, up to 36, and then a little bit up on 48, another drop of 60 possibly with by a bias or statistical error, having less patients on the 5 years. Also, at least 12 meta-analyses were produced, like this one of the newest one by São Paulo University, meta-analysis that could enroll or put together 1,859 patients with total body weight loss at 24 months of 14.86%. And also the excess weight loss at 24 months of 60%. And the pooled severe adverse events were 2.26, so very low severe adverse events. So you can see here in this meta-analysis graph that if you go down below where are the black losangles, they are the results from up to the bottom, 6, 12, 18 months and 24 months. So all of them over 15% of total weight loss. That's pretty good for endoscopic procedure. And this is our Brazilian consensus of zygostoplasty with more than 1,800 patients. That it was a collective effort of 47 endoscopies with a mean of 15 years of experience and a mean number of cases per participant of 87 procedures. They all trained in a very standardized fashion that's very unique for endoscopic or surgical methods, and they had used the U-shaped suture, as you can see here, the initial U-shaped pattern and a modification of this one that's called square that is being adopted lately. So in terms of complications, less than 1%, most of them bleeding with conservative treatment, to prolonged pain due to CO2, one persistent vomit, one respiratory insufficiency, and very important, 3 laparoscopic intervention, 2 for abscess, 1 for gallbladder puncture and suture, and this is the very first time that a death is reported, and was in a high-risk patient that developed pulmonary embolism, and there was the surgery that indicated that for the treatment. And interestingly, also the results were 18.2% of total body loss, very good results indeed. Also, as we mentioned earlier, we just finished the enrollment, and we followed these patients for 2 years. That's in MERIT trial, prospective randomized controlled trial against diet. You can see by the institutions that are participating, it's a very important trial. So I have Mayo Clinic, Cornell, UT, Harvard, Hopkins, and quite some very good private centers in the US. So it's 200 patients. They were randomized to have 80 on the endoscopic procedure, 120 on the diet, and after 1 year, they were being crossed. The ones with diet will have the procedure, and the ones with the procedure will be followed to assess the need of resuturing or reintervention for that. So it is a gastroplasty. Vessels and nerves are preserved. We leave the fundus as part of the procedure in order, and it doesn't lead to reflux. So this is not a refluxogenic procedure like the gastric plication, not like the sleeve gastrectomy. And the stomach intraluminal pressure is kept at the low levels because of the compliance. It's keep it, and the peristalsis is kept on that. So it works by restriction, by delay the gastric emptying, and we don't know yet if it changed or not the GI hormones on that. So you can see here, this is coming from Mayo Clinic, courtesy of Professor Brahma Budaye. So it's a dynamic MRI. On the top part to see the heart beating, and on the lower part to see the liver and the stomach that was sutured, but keep the capability of contract and relax over that. So how it works, this is scintigraphy, and you can see the color part with 240 minutes. 3 months after the ESG, still retain a lot of food there. And this also this tomography done in the contrast is retained on the fundus even after 1 hour after the ingestion of the contrast. So this is a new data coming from the MERIT trial that you can see here, that on the left side are the controls, and then it's the ESG patients in terms of gastric emptying at baseline 3 months and 12 months, how we keep delaying the gastric empty. Complications, as we said, low rates, most of them solved by endoluminal transcutaneous conservative approach. Long-term specific complications are not identified up to now. And it was we were anticipating on this slide, the mortality was not yet reported, but our paper have reported the first mortality with the procedure, and is one report among more than 15,000 cases done worldwide in that. So as we told you, that's collectively, and all the papers like this is a paper that we analyzed 248 patients in between Madrid, Cornell, and Mayo Clinic, and you can see here 2 pergastric fluid collection, percutaneous drainage, 1 pulmonary embolism, so very clinically, self-limit bleeding of splenic laceration, and 1 pneumoperitoneal pneumothorax during the procedure that also treated conservatively on that. So those are the difference in between those procedures. That was the question that Dr. Shashank Shah asked me to try to solve it, and I will end up showing to you that is already being published comparison in between laparoscopic weight curvature application, sleeve gastrectomy, and endoscopic sleeve gastroplasty up to 2 years. And you can see here it was just recently published by the Spanish group in endoscopy, and you see here 296 patients from 4 centers in Spain between 2014 and 2016. So there's a clear advantage in terms of weight loss for the surgical procedures. But the endoscopic procedure on the top, as you can see, 18.5% of total weight loss up to 2 years is not bad at all. The trade-off is that when we see the complications, the endoscopic procedure significantly have less complications than the surgical procedures, and also the patients go home earlier with endoscopic procedure when compared with the surgical ones. So I wanted to thank you very much for your attention, and any questions we can solve it later.